So our next speaker should be familiar to all of you. Brianna Hoffner has been part of our program. We'll be celebrating our third year having her as part of our program in a couple weeks, but has brought something different to our program. The ability to have the experience from her previous places being Memorial Sloan and University of Colorado, and the ability to say, look, when I was at Dana-Farber, this is what happened, this is how we help patients, and these are the ways that we can improve our program for our patients. She's been an amazing contributor and a co-investigator on all of these trials that you see here, not just leading as an investigator, as a patient advocate, but leading as a nurse practitioner for her group of providers. So it's with great enthusiasm that I introduce Brianna Hoffner, reintroduce her to you. She can talk about the best part of what we do, the survivorship. So Brianna.
Okay, I forgot my tie, so I'm just going to hold this. It's going to be fine. Thank you guys so much. It's really an honor to be here. I'm excited to do this talk. It's nice to be batting cleanup for such a prestigious lineup. I suggested that I should have at-bat music, but I knew that Dr. Hamid would want the Lego song, so we kiboshed that. So, you know, I kind of struggled with this talk because I didn't want to sound like a hypocrite standing up here telling a group of survivors how to be a survivor. So I'm going to tell you a little bit about the history of survivorship, a little bit about the common things that we see in our clinic, and then kind of a snapshot of where we are and where we're going. This quote I just liked. I think the idea of being a possibilitarian is a great idea, and that's sort of where we're at based on everything that you just heard from all these great speakers. So the definition of a survivor is any person who has been diagnosed with cancer from the time of diagnosis throughout the person's life. So from the moment you're a survivor, or from the moment you're diagnosed rather, you are a survivor. And I love that idea because it's very all-encompassing, and it's true. It's true. It's quite a process. So seasons of survivorship. In 1985, Dr. Fitzhugh Mullen published Seasons of Survival. And he was a doctor who was also a cancer survivor, and he outlined 3 different seasons of survival. He said that you have the acute survivorship, which is right when you're diagnosed and you're going through the initial treatment. The extended survivorship, which is a time of watchful waiting with celebration. Certainly we've all had some celebratory scans, and uncertainty and transition. And then permanent survivorship with the season of gradual confidence that there would be a future free from cancer. So that's what we want to be able to provide everybody, is that confidence that there will be a future free from cancer. So then in 1986, Dr. Mullen helped create the National Coalition for Cancer Survivorship. And in 1996, the Office of Cancer Survivorship was founded at the National Cancer Institute. In 2004, the National Coalition for Cancer Survivorship, the National Cancer Institute Office for Survivorship, and the Centers for Disease Control and the Lance Armstrong Foundation, some big heavy hitters there, all got together and they collaborated to publish this article, A National Action Plan for Cancer Survivorship, Advancing Public Health Strategies. So basically what they were trying to do there is set forth some goals for cancer survivorship. We were arriving at a really unique place where we've gotten so much better at treating not just melanoma, but a variety of cancers. And so all of a sudden, this is something that we really need to address, is how do we meet these changing needs? So this was a great group that got together to start that conversation. So in 2005, the Institute of Medicine published From Cancer Patient to Cancer Survivor Lost in Transition. And this, I'm not going to read to you, of course, but it really touches on a lot of the issues that cancer survivors encounter. And what the conclusion that they came to is that there's a lot that can be done to either avoid, ameliorate, or arrest these effects of cancer. And that's our responsibility for you guys. And so the recommendations of this report was that we recognize survivorship as a distinct phase of care. So really there, when they talk about survivorship, they're talking about the phase after treatment. Ensuring delivery of appropriate survivorship care, so that's been a challenging thing for all of us. Expanding research efforts in survivorship, eliminating discrimination, and ensuring access to health care. So then we came back to Seasons of Survivorship in 2008, because this landscape has changed so drastically. And Dr. Ken Miller, he was previously the director of the Lance Armstrong Foundation at the Dana-Farber Cancer Institute. That's their survivorship clinic. And he wrote Seasons of Survivorship Revisited. And he added a few things. He added this idea of a transitional survivorship, which is the time immediately after treatment ends when celebration is blended with worry and loss as the patient pulls away from the treatment team. So, it's an interesting time for us after months and months of hearing you guys tell us about the traffic on the 405 getting in. It's just ridiculous, getting changed by appointment time. And all of a sudden we say, we will see you in 3 months. And you all look at us like, what? What are you talking about? And it's hard. It's a really difficult transition to make. And then extended survivorship includes those who are living with cancer as a chronic disease, and permanent survivorship. And this I really loved. It talks about those who are cancer-free but not free of cancer. And that's a really interesting concept. We have treated you guys, we talked about all these different treatment modalities today, and a lot of you have seen a combination of those therapies, and they have side effects, So we may have cured your cancer, but you may have tingling in your hands or your feet, you may have thyroid dysfunction or things like that we've left you with as a side effect, and we still need to manage those things. So by the numbers, there's about 14.5 million cancer survivors living in the United States, and that's projected to be about 18 million by 2022, because we are doing so well with advancing our treatment modalities. By 2020, the increasing population is projected to increase the cost of cancer care by 27% to over $157 billion. So this is a big industry. It's something that we all need to pay attention to. National medical expenditures associated with being a cancer survivor range from $25 to $48 billion, and loss of productivity among cancer survivors ranges from $8 to $16 billion. So financially, this is a big issue as well. So I want to talk about some of the common themes of survivorship, and I'm doing this more in the spirit of saying, whatever you're going through, you're not alone, rather than trying to tell you what you're feeling or how to feel it. So we'll just touch on some of the things that we see a lot in our clinic and others. So fear of cancer recurrence, this is probably the biggest. Once we get patients through a treatment and we say, you're doing great, we will see you in 3 months for follow-up scans, that's really hard to walk away and feel like you're gonna be okay. So strategies for coping, all these recommendations are coming from extensive literature reviews of different people's ideas on how to get through this. So acknowledging your fear, saying that this is scary, that's okay, we get that, this is scary. And talking about it with your family, your friends, talking about it with us so that we can try to help you through that. Living your life. We always say that we want to give you both quality and quantity of life. So when we give that back to you, we want you to be able to enjoy it. And so go out there and do the things you want to do. A lot of times asking about the signs of recurrence can be really comforting for patients because the fear of the unknown is the worst. So, you shouldn't be afraid to come in and say to us, what do I need to look out for? What should I be worried about? When should I call you? We're happy to go through that with you, and a lot of times that can make you feel much better. And then getting help with emotional stresses. Fear of recurrence can be linked with anxiety and depression. Really common. We're going to talk a bit more about that. And then understanding how your emotions change. We put you through all these different therapies, and the way that you feel things is different emotionally and physically after cancer. So another huge one is cancer fatigue. This is really, really tough. And very multifactorial. There's a lot of things that contribute to cancer fatigue. So among those are sleeping problems, depression, endocrine abnormalities, which we're seeing more and more of with these immune therapies that we've talked about today, and deconditioning. Going through these therapies, we really break up the workout routines. Sometimes you're not feeling well, and when you come back to exercising, it's much harder to get started again. So some strategies here from the literature, monitoring your sleep habits. Write down when you're going to sleep, when you're waking up, how much sleep are you really getting? A lot of people have those bracelets now that monitor your sleep. Those can be really helpful. Sometimes you feel like you are doing a good job with that, and in fact, you're not. We had one patient who said that he was exhausted just really couldn't even get out of bed in the morning. And after a long conversation, it turns out that they had bought a new like solar system sleep machine thing that was projecting stars on the ceiling, and it was keeping him up. So we got rid of the solar system, and his fatigue improved. So it's funny, you don't think of these things sometimes. Getting enough exercise. Exercise actually really does improve your energy. Eating a balanced diet, so we are going to talk more about diet and exercise. Watching for signs of anxiety or depression. These things come up a lot of times. Your friends and your family members are the best ones to say to you, listen, you don't seem quite like yourself. And that's okay. There's a lot of options for that too. And then talking to your care team about your fatigue. As you guys know, a lot of you will come in and say, I feel exhausted. This is not me. And then there's a lot of labs that we can run. We can look to make sure that you're not having endocrine abnormalities or electrolyte abnormalities that would contribute to your fatigue. So depression and anxiety, this is really common. About 30% of patients in active treatment experience clinically significant psychological distress. So clinically significant meaning that it could be associated with a psychologic diagnosis of something like anxiety or depression. But certainly there's patients beyond that who maybe would not carry a diagnosis but have a lot of anxiety and distress. About 20% of post-treatment patients experience depression. People feel really guilty about this. They finish their therapy and they think they should feel really good and grateful that they're doing so well. And a lot of times that's a really hard period, and that's okay. You're not the only one who feels that. This is common. So recognizing the symptoms of depression versus anxiety, sort of a not comprehensive list, but some of the most common things we see with these diagnoses, and seeking help if you need it. Oftentimes we are not the best person to help with that. But we can be the best person to help liaise and get you set up with somebody who could help, get you started on something, short-acting things like Ativan that can help with anxiety, lots of different options, and we're happy to talk about those. And then consider a support group. So support groups, as you know, can be a real double-edged sword. They are a great idea for some people and not a great idea for others. And so that's really patient-dependent. If you are somebody who really feels the sense of community within a support group and likes that idea, that's great. If you're somebody who counts heads at every single support group, and if somebody doesn't show up, you want to know exactly where they are because that's very anxiety-inducing, it's not going to be the right setting for you. So something to think about. Cognitive changes. So cognitive changes are incredibly common. A lot of you guys have said this to us. I like this cartoon because it depicts somebody trying to do something that usually they can do. And that's what we see a lot of with the cognitive changes associated with cancer therapies. As patients will come in and they'll say, I don't remember the password to a single one of my bank accounts. And it's a real problem. And things like that. And so this is something that we need to address. So strategies for coping, pace yourself, be gentle with yourself. Understand that you're going through a lot and take a step back. If you're multitasking, try to focus on one thing at a time. Make lists if you need to. Writing it down can be really helpful. Sticky notes all over the place. That's what our office looks like. And then be aware of other causes. Problems with memory can be caused to other things like sleeping poorly or to having endocrine abnormalities, electrolyte imbalances, as we discussed, and also to emotional issues like depression and anxiety. So a lot of these things are all connected, and that sort of highlights the importance of talking about them so we can sift through and figure out how to prioritize. So family relationships, this is a really tough one. Family dynamics and roles change during the course of treatment, and after a cancer diagnosis, it's hard to return to the old routine. Things are not the same again. To think that things are going to be exactly the same is not maybe realistic, and that's hard because how do you move forward in a healthy and productive way? So for this, the idea of being really open and honest and having family conversations, say, this is hard for me. As a family member, it's okay, it's not a selfish thing to say that it's hard for you too. The extended diagnosis of cancer survivorship is to include all the family members who are also going through the cancer diagnosis with their loved one. And so this is a real thing. And talking about it as a group, as a family, is also very helpful. Sexuality and intimacy. This is something that I think a lot of people are afraid to ask us about. About half of cancer survivors experience post-treatment sexual difficulties. So this is really, really common. And I can tell you that not half of our patients are coming in to talk to us about this. And I think that that's difficult. And so I want to say today that this is out there and that there's options. So strategies for coping, talking with your partner about it, that's probably the first step. Being really honest, know where each other is at and how to move forward. Taking it slowly. As you go through treatment, you're changing physically and emotionally, and that changes the relationship. And so you need to take it slowly. And then getting in touch with your body, you have, as I just said, a port here, a scar here, things that weren't there before, and that changes intimacy. And then reaching out for help if you need it. You can ask us about things that we could do to help, or referrals that we can make to help. Because for things like painful intercourse or erectile dysfunction, there's a lot of treatment options, and so we can work through that. And so going along with that is fertility issues. Fertility issues is something that certain therapies can cause significant fertility issues. And if fertility is something that is a concern for you, it's really important to talk to your team up front and say, these are my priorities before you get started with your therapy, and I want you to know that because there's options. In terms of cost of these infertility therapies, that continues to be a bit of an issue for many people, but there's certain foundations that can help make these infertility treatments available prior to starting therapies so that patients can still maintain that option further down the line. So the benefits of exercise. Studies suggest that cancer survivors who exercise regularly may feel better, have less fatigue, and experience fewer symptoms after treatment compared to those who do not get regular exercise. So this is what Dr. Hamid and my exercise routine looks like in the office. So we are not the best examples, but it's true. Getting exercise is something that really makes a difference in terms of how you feel emotionally and physically. The American Cancer Society recommends 30 to 60 minutes of moderate to vigorous exercise at least 5 days a week. So that's a lot. That's a tough thing to do. But suggestions for fitting that into your day is starting a daily walking routine whenever possible. And here in Southern California, it's much easier than where I grew up in New England because you don't have to contend with weather in most cases. And walking or biking to your destination when you can. And then exercising with family or friends or coworkers, having somebody there who motivates you to do this on the days where you're tired and you really don't feel like doing it. And then using a stationary bike or a treadmill, that can be great. You can sit, you can read People magazine, get a little exercise, multitask. So that can be a good option as well. So nutrition, good nutrition supports healthy survivorship. We all know that. And nutrition questions, this is also a little too close to home, but nutrition questions come up a lot. What can I do to help myself is really the question around nutrition. So a lot of text on this slide. I'm going to hit the highlights. So essentially what we recommend is eating a well-balanced diet. We don't recommend going on a lot of these diets that you read about, alkaline diets and this diet and that diet. What happens is patients will lose weight and then they'll have electrolyte abnormalities and we'll have a difficult time getting them through treatment. And so we really ask that patients maintain a well-balanced diet, fill your diet with fruits and vegetables, look for high-fiber foods, choosing low-fat or non-fat milk and dairy products, go easy on fat and salt. Also go easy on red meat. That's one thing that we do know can increase your risk. So we ask patients to sort of go easy on red meat. It doesn't mean you can't have a burger every now and then, but it shouldn't be your daily routine. Trying new ways to cook, such as broiling, steaming, or baking foods instead of sauteing them or frying them. And then eating with others, making it a social event. It's a nice thing. It helps. It fosters good eating habits. Eating small meals. It's better to eat 4 or 5 small meals per day. Sorry for the typo. Than eating 2 to 3 large meals. And then incorporating exercise to stimulate your appetite. So spirituality, this is also a tough one. Spirituality is not limited to religious traditions, but certainly that's part of it. Religiosity and spirituality are sort of 2 different things. I can tell you that I grew up in a very Irish Catholic household. We had to go to church every Sunday. And when my dad was diagnosed with cancer, he has not been to church since the diagnosis. My mom became a yoga instructor, and she teaches a Sunday morning yoga class that they both call church. So, spirituality changes, and what is right for you at the time might be different as you go through the cancer process. So meeting with a therapist to learn about things like mindful meditation, or reaching out to somebody who you feel comfortable with. If you have a priest or a chaplain or a rabbi or somebody that you connect with, that's a great option. Really, it's whatever feels good to you at the time. Integrative medicine is also something we get asked about a lot. And there are so many different integrative medicine approaches. This is not a comprehensive list for sure. It's something that we really support. I think that mixing integrative medicine with our therapies is a great idea in general, but it's something that you need to talk to your care provider about. You know, for example, acupuncture, there are times where you are at increased risk for bleeding or infection based on your therapies, and that wouldn't be the right time for acupuncture. Or some of these homeopathic remedies, these herbal things, in the middle of a phase 1 clinical trial, also not a great time for that. So we are really open-minded to this, but we want it to be a conversation. So if you want to talk about these things, please bring it forward, and we can figure out where to fit it into your treatment plan. So communicating with your care team, this is also another tough one for survivors, is how to talk to us about the things that are bothersome to you. So, you know, we kind of went through a list of the most common things that we see. That is not a comprehensive list, but you've got to be able to tell us what's going on. So it's hard, you walk into the doctor's office, and as soon as the doctor comes in, you forget everything that you meant to say. So writing it down can be really helpful. Be prepared for your visits. You know, ask us everything you want to ask us. We're there to answer questions, and we're there to help. And then asking about potential long-term side effects of treatment and warnings that you should be aware of. This is what I was saying about ignorance not being bliss. You know, you guys need to be well informed about what to worry about, what to look for, when to call. Verbalizing your fears about follow-up care, also an important one. And then keeping all members of your care team in the loop. So if you're doing something significant with your cardiologist, we'd love to know about that. You know, and vice versa. We want to keep your care team members in the loop. So tell us who you're seeing. Tell us what's going on. We're happy to facilitate that. Genetic risk, this is something that a lot of people worry about. Only about 5% of all cancers are inherited, actually. So genetic testing is not regularly recommended for our patients. However, there are certain circumstances where it is appropriate. So this is something that you can ask about. Things that you can do, though, to help yourself in general, we know that anybody who has had a cancer is at higher risk for a second cancer, and so you should still do all the same screenings. You know, because you've had melanoma does not mean that you have no risk for breast cancer or colon cancer. So you should still get mammograms, still do your colonoscopies, still do all those types of things. And then ask if genetic testing is appropriate. You know, we've talked a lot about BRAF mutations today, and that's not a genetic mutation, that's a somatic mutation. So that's an important difference, but that's a question that we get asked a lot. So if you have these questions, please bring them forward. Care plans. So survivorship care plans is sort of a hot topic in survivorship care right now. They are recommended. The Institute of Medicine report that was published in 2005 strongly recommends the survivorship care plans. And there's two components to care plans. There's a treatment summary and then the follow-up care plan. And the recommendations of what these two parts of the care plan should include are really comprehensive and exhaustive. They want you to have all the dates of your procedures, your therapies, what types of therapies were used, and then what the expected course of recovery is going to be like, what the toxicities are going to be like, possible long-term and late effects, etc. So the goal for a care plan is really, really lofty. So how are we doing? So this was based on an article that was published in the Journal of Clinical Oncology that polled primary care physicians, oncologists, and patients about certain survivorship issues, and they asked them all who should be responsible for what. And it was like that scene in Alice in Wonderland, you know, with the two dodo birds who are pointing this way, you know, when she asked where to go. Nobody really agreed on who's in charge of what. And that's a problem. That's a big part of survivorship care issue right now, is who's going to take care of your high blood pressure. You know, if we gave you a medicine and it caused high blood pressure, do we take care of it because we gave you the chemotherapy that caused it? Or does your cardiologist take care of it? Or does your primary care take care of it? And we need to divvy those things up. So the places where we were most off track, patients and oncologists had different opinions in terms of screening for secondary cancers. So patients believed that their oncologist should be fully responsible for that, should be looking out for these things, telling them when to get their colonoscopies and mammograms, and looking out for that, versus oncologists felt like that was more of a primary care issue. Primary care physicians more frequently believed that they should be primarily responsible for cancer follow-up as compared to patients. So the primary care physicians thought that they should do all the follow-up for your melanoma, versus patients thought that should be their oncologist. And then primary cares and oncologists were a little off base in terms of cancer surveillance, cancer screening, and preventative health. So that was an example of like the endocrinopathies, the hypothyroidism that we see a lot. A lot of the primary cares thought that if we have caused this with our medications, we should manage this, versus oncologists thought that they caused it, but we don't know how to manage it. Maybe we should send you to a primary care and an endocrinologist. So the moral of the story is that we need to have this discussion and we need to get on the same page. There's no right answer, there's no standard answer, but we need to talk about it and make sure that somebody is taking care of these issues, because certainly we just can't assume that somebody else is doing it. And then this was another Journal of Clinical Oncology article called "Don't Let the Perfect Be the Enemy of the Good." And I think this was in 2012 or 13. And basically what they were talking about was the Institute of Medicine report that had set forth those goals for survivorship care, what our priorities should be, how we should do it. And that report had also talked extensively about the care plans. And so the care plans are tough for these reasons. The evidence for survivorship care is weak. We don't have a lot of information about it. It's still relatively new and we're still learning. What are the important things and what do we need to know? The evidence for management of the long-term and late side effects is also sparse. We are just getting to the point where patients are surviving for years and years and years after a melanoma diagnosis, and so we're not exactly sure. PD-1 drugs have really only been around in patients for about 3.5 years or so. So we're not sure what the 10-year effect of a PD-1 drug is, but we are going to learn that, and we know that from all these wonderful durable responses, but we have to figure that out. And then survivorship care is unfunded. Dana-Farber has an incredible survivorship care program, but they were funded by millions and millions of dollars from the Lance Armstrong Foundation, and that's how they get that done. Insurance doesn't pay for any of it. They did a feasibility study looking at how hard it is to do these care plans. And they stated that to do a care plan for a patient took a provider about 2 to 2.5 hours to put together. And then, in addition, all the follow-up for the care plan. So that's a tough thing to do, to find that amount of time. And additionally, we don't have the same sort of impetus for a time point to create that. We used to have these therapies where you got 4 cycles and you were done. But now with these PD-1s, it's indefinite dosing at this time. And so when in that indefinite dosing would we generate a care plan for you? And we're not quite sure what the answer is. But the point of this article was trying to say, let's not be discouraged by the fact that we haven't gotten there. Let's be encouraged by the idea that this has been brought forth as a conversation and we're making progress. We're not there yet. We need to redefine some of these things, revamp our plan, and we need to move forward. So the take-home message is there's a lot of common themes of survivorship. Whatever you're going through, you're not alone. As our treatment modalities improve, the importance of survivorship care increases, and we've made progress, but we're not there yet. Thank you.